Often as house surgeons, one of the biggest dilemmas is how much should we be acting independently and when should we be asking for help? None of us want to be bothering our seniors unnecessarily, but equally, how do we know what we don't know and whether that could be critical in a particular case? Sometimes we can be embarrassed to ask for help if we think it's something we should be able to make a decision on ourselves. And maybe in the past we've been made to feel stupid or that we're an annoyance when we've asked for advice. So today we're looking at an HDC case which hinges on an RMO not knowing some critical bits of information and making a decision with the patient's best interests being at the front of their mind, but with disastrous consequences. Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medical legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today in the studio we have Adam Holloway from Wood & Kearney, our panel law firm. Hi, Adam.
Hi, Lucy. Thanks for having me.
And Sam King, who's one of the medical legal consultants from MPS and a GP. Hi, Sam.
Hi, Lucy.
My name's Lucy Gibbard. I am also a medical legal consultant at MPS and a GP. So we're going to look at an HDC case, and the way we're going to approach this podcast is I'm going to tell you the clinical story, and we're going to stop at various points to discuss the medical legal situation and the risks and the considerations for that part of the scenario. The idea is that we can put ourselves in the RMO's shoes and think about, with the benefit of hindsight, what might have been done differently. Now, this RMO did not have the benefit of hindsight, and I think it's always really important when we're looking at cases that we don't become too judgmental, because the truth is, in our careers, we're all going to have cases where we wish we'd done things differently. We're here to learn, and hopefully that will help keep us and our patients safe. So in this case, a 77-year-old man presented to ED via ambulance in a regional hospital with an ischemic stroke. He presented 2 hours after his symptoms had first started, and it was late at night. He was first assessed by a house surgeon, Dr. A, and it was around midnight. The house surgeon's note record that Mr. B had left-sided neglect, a complete homonymous hemianopia, that's a hard thing to say, and weakness of his left arm and leg. The diagnosis was a stroke, and the house surgeon considered that as there were no contraindications, depending on the CT result, that thrombolysis was indicated. The house surgeon had never actually provided this treatment before, and so discussed the case with the on-call consultant, Dr. C. Dr. C listened to the clinical findings and agreed that the risk of thrombolysis was justified. So the house surgeon had never provided this treatment before. Do you think that the SMO should have offered to come in at this point? Sam?
Not necessarily. I think that if they weren't going to come in, I would have hoped that they would have asked the house officer some questions. You know, have you done this before? Are you confident? Do you need me to come in? You know, all of those sorts of things. And talked the house officer through some common pitfalls of whatever the treatment is, you know, for providing thrombolysis. And so I don't know that the SMO had to come in, but I would have hoped a conversation would have taken place, not just, yeah, that's fine, go ahead, and put the phone down. And I guess the issue is the threshold for SMOs coming in. I mean, you hear of all, you know, I'm sure many or most SMOs are really appropriate in that they will come in if they think it's necessary. They have a low threshold for doing that. But I'm aware that there are some SMOs in the country, of course, who have a high threshold. And in this situation, in this particular hospital, there was no registrar, and which means that the SMOs would have had an increased workload and, more pressure. They probably needed their rest. They probably were thinking, oh, it's nearly time, I've got to make my bed, all those sorts of things. And it can form a barrier. And I'm sure it's difficult for SMOs to find that right balance. But I guess, house officers, particularly if they're new, never done it before, they need support. And that's what the responsibility is.
It was noteworthy for me that there was no registrar, which suggests it's probably a small regional hospital, which also means there may well have been almost, highly likely no SMOs in the hospital overnight. And so you've got a house officer running ED, relying on an on-call, but also nobody else to turn to. And look, I'm not a clinician, and it's not for me to make these judgment calls, so I'm hesitant to say the SMO got it wrong. But if you're thinking about what can go wrong with thrombolysis, and if you're unlucky and something does go wrong, what is the necessary response to that? And thinking, in an environment where there are no other senior clinicians to turn to, is the house officer going to actually be capable of dealing with that worst case scenario? I would hope that that's one of the thought processes running through the SMO's head.
It's also hard for the SMO. It's the middle of the night and you've just been woken up and you're probably not thinking quite as straight. But, I always think it's one of the things with from the house surgeon's point of view, if you haven't done something before, should you specifically ask? Should that house surgeon have said, I've never done this before, please can you come in? Is that responsibility on the house surgeon to specifically ask, do you think?
That's a very broad question. I guess I'm speaking from the position of the legal equivalent of an SMO. I would hate to put my juniors in that position. Like I'd want to have a work culture where they felt very comfortable asking, but I would also hope to be responsible and insightful enough and to carry enough of the responsibility that I wouldn't put them in a position of needing to ask.
Right. Okay.
Is that,
fair enough. Yeah, fair enough.
It's tricky though.
Given the fact, if you are working for an SMO who perhaps is a little more distant than that, and let's face it, for some SMOs, they might think this is routine. We do this all the time. There's nothing to it. Forgetting that this is completely new for a house officer. I would hope that house officers have the courage to be able to speak up for themselves, because the risk to the patient is high if you get it wrong. And even if it's just, you can be polite. Be polite, be respectful, but be assertive for yourself. And, there's nothing wrong with just saying, I've never done this before. Would you mind coming in? Or I've never done this before. What's the protocol? What can you tell me that I need to do? Can you just talk me through it? And so that you're more confident going into this new procedure.
And if you specifically say that I've never done this before, you would hope that the SMO would take a cue from that and say, would you like me to come in? I think letting the SMO know that you've never done it before is probably a good thing to do.
It is missing out the first step of the see one, do one, teach one.
Oh, right, it is, yeah, absolutely.
Yeah, I think too, if it's always good to document those conversations well, that if you've raised an uncertainty and have asked the SMO to come in and they decline, I think it's important to document that you have asked them to come in. And just from a medico-legal perspective, it will help to remind you when it comes time to responding to a complaint that that's exactly what happened. From a human factors perspective, as I mentioned earlier, you're phoning the consultant out of hours. They're likely to be doing other things. And our listeners might like to consider stating what is most important up front. So you might want to say, I would like you to come into the hospital to assist with the patient, and put that up front. And this immediately communicates the purpose of the call and allows the consultant, particularly if they've just woken up, to understand the level of concern straight away. And then there's no doubt that you have made this request.
So Mr. B's CT scan showed no contraindications to thrombolysis, and Dr. A called his consultant again to confirm that thrombolysis was indicated. So that was, he called back. The consultant instructed the house surgeon to give thrombolysis as per the thrombolysis guideline. So, Sam, if an RMO has never given a treatment before, is it okay, to follow a guideline? Is it see one, do one, teach one? Or can you say, no, there's a really good guideline and I can give it without specific training or supervision because the guideline tells me what to do?
I think it depends on what the treatment is, about the potential risks of that treatment. If it's fairly low level and straightforward, there's no reason why you can't just follow a protocol. I think that, the higher the risks, the more important it is to seek clarification. And when you read a protocol, if it seems very straightforward, do A, then B, choose this file, it's the colour green, it'll be sitting in this cupboard, those sorts of things, then you can follow it step by step and obviously be careful to follow the steps as laid out. But I think that if there is anything that you're not clear about, it's important that you clarify that.
And I do think there is that issue that nurses often get accredited to do certain procedures, whereas there doesn't seem to be that system so much for doctors. And sometimes it's actually quite a useful idea to think, am I the equivalent of accredited? Have I got enough experience to do this?
Yeah, I was talking to some SMOs recently, talking about being accredited for certain things. And I think that these days, compared to when we were house officers, it's much better. But they did say to me, you'd be surprised how few processes are in fact accredited. In other words, it's still see one, do one, teach one. Watch the YouTube clip and go ahead, which is a little bit scary, really.
Yeah. So in this particular case, thrombolysis was actually started in ED. Now, the hospital later updated its protocol to say it should only be given in ICU, but that wasn't part of the guideline at the time. The ED orientation stated that thrombolysis should not be given in ED, but at the time of the HDC case, no one knew if that document they were looking at was the same as the document had been at the time of the case. And I think we often come across that problem, is that documents get updated and guidelines get updated, and it's really hard to know what an old document or guideline said. So, Adam, do you think RMOs should be identifying in the notes if they're using a protocol or guideline and specify what the date on it? Is that an issue?
I think they should, in a situation like this, specify that commencing thrombolysis in accordance with protocol, it would be a counsel of perfection to say, look at the bottom right-hand corner in the footer for the version ID and write that into the clinical record. On one take as a lawyer, you can say, well, that would be a great idea, because in the 1 in a million chance it becomes relevant to a complaint later, you've got it there in the notes. I think it's probably unrealistic
I agree.
to ask for that. You can't get away from the fact that you've got a 77-year-old with an acute stroke in front of you, and actually that's what you've mostly focused on, is whether or not you can give this gentleman the benefit of thrombolysis to improve his outlook. So I'm not at all critical of someone who didn't write that detail down. I don't think it would be expected. But I think it is appropriate that you note that you are following our protocol when you are engaging in this.
Which I think they did, yeah.
Yeah.
I mean, it might be one of those things you do later when you were talking about, in our previous podcast about writing notes after something's gone wrong, that actually it would be a useful time to write notes about what happened, but also maybe print out a copy of the protocol and keep that as well.
That's a great observation, Lucy. Yeah, if it's immediately apparent that something has gone wrong and that this will be looked into either by the hospital or the HDC, then taking a moment to capture that information, think, okay, well, central to what I did here is that I followed a protocol. I'm going to go and navigate to it and print it out, or if it lives in a cupboard, I'm going to go and take a photocopy of it.
A nurse suggested to the house surgeon that maybe they could call the ED SMO, but the house surgeon said that she would talk to the medical SMO instead. So the ED nurses are often very experienced and will often make helpful suggestions, such as this one, who suggested that the ED SMO should be called back in to assist. How much weight should we give to suggestions by other health professionals, such as nurses, who may have more experience than you as an RMO, but they're not carrying the responsibility that you're carrying as a doctor in that situation? Sam, have you had any thoughts about that?
Yeah, look, this is really tricky for house officers. We know how the hospitals are very hierarchical. You're talking about different disciplines, and sometimes there's a bit of tension there between nurses and doctors or whatever, different staff. And so it can put the house officer into a difficult position, particularly if the house officer is feeling uncertain about what to do. But I would take into account what the nurses have advised. But at the end of the day, if you're the doctor signing the medication chart, you are responsible for what you have charted. And your line of accountability is not to the nurse. Your line of accountability is to the registrar or the SMO. And, nurses, whilst they see a lot, they've never had the responsibility of prescribing. So it may be that they've never fully read the protocol, they've never seen different situations necessarily or what's happened around that or the different prescribing. So I would take an experienced nurse's comments as a suggestion, but not as an instruction. And if there's uncertainty, I would certainly clarify it with a senior doctor. And that senior doctor might be the ED SMO. We have to take into account, local practices, and in some EDs, the emergency consultant responsible for the department would expect to be informed when a high-risk, time-critical intervention such as stroke thrombolysis is being undertaken in the ED, as they have overall responsibility for the department. And they can also provide oversight, support or assistance as another potential decision maker. So I think it's worth considering that.
So at the time, there was only one other doctor in the hospital who was actually less senior than Dr. A. And that Dr. A thought that it would be better to keep the patient in ED where there was going to be better oversight than in ICU, and was also concerned that transferring the patient to ICU for thrombolysis would actually cause further delay. And that window for thrombolysis is a significant consideration. And I think in this particular case, that time pressure that you have to do something by a certain time is actually part of the issue of why problems arose. The house surgeon says that no one suggested to him that the patient should be moved to ICU, and he wasn't aware that that would have been standard practice. So this is where we don't know what we don't know comes in. This house surgeon did not know that thrombolysis for strokes had always previously been given in ICU. Is that his fault? Can he be criticised for not knowing that?
Yeah, it's... so much depends on the facts of the case. If there's been no prior induction training, or it's not clear from the protocol that it would normally be given in ICU, and that house surgeon hasn't previously had training in another setting that thrombolysis is something that you only ever give in ICU. If the SMO that they spoke to and were effectively given permission to proceed, hadn't mentioned the setting, I would be slow to criticise them. I think if an experienced nurse suggests calling someone in and the doctor has said, I might try and talk to the general med SMO instead, it suggests to me, again, there might be something going on there in terms of the approachability or, whether or not that initial call went well, or that the junior doctor felt supported, that they would then divert and think, well, no, actually, I'm going to call a different consultant. That's...
I think he'd been calling the Gen Med consultant the whole time. He's been calling the Gen Med consultant, and the ED nurse obviously probably has a relationship with the ED SMO, and so says, "Oh, let's call them." So, I think you're right that sometimes there is that reticence to actually call because of relationships or past experience and all those kind of things.
Yes,
I cannot see how you could criticise the house officer for not knowing that it was routinely done. And I see if it's not, if it's routinely done there, it ought to be in the protocol, and that's a systems matter, isn't it?
So Dr. C, the medical SMO, did not tell Dr. A to take the patient to ICU. She'd actually assumed that would be done because all previous thrombolysis have been done in ICU. She wasn't aware that thrombolysis for myocardial infarctions had recently been started to be given in ED. So, she just assumed the patient was in ICU and they weren't. So just some background clinical information here. The thrombolysis used for strokes is called alteplase, and it's an infusion that's given within 3.5 hours of onset of stroke symptoms. Its brand name is Actilase. Now, this point becomes relevant later. The thrombolysis used for myocardial infarctions is tenecteplase, which is delivered as a single bolus. So the ED nurses had recently had training in providing tenecteplase as thrombolysis for heart attacks, but they hadn't been trained in using alteplase for strokes because that usually happened in ICU. The hospital had a very specific consent form for providing alteplase on the stroke pathway, which includes the option for verbal consent to be provided for someone else or for someone else to sign on behalf of the patient. Obviously, some patients with a stroke aren't going to be able to sign their consent. In this particular case, Mr. B's consent form wasn't signed. Dr. A said he was not familiar with that part of the protocol, but Mr. B's verbal consent was recorded in the electronic discharge summary. Dr. A did actually also talk to the patient's wife by telephone to explain the proposed treatment and associated risks. And both Mr. B and his wife indicated that he wanted the treatment. Mrs. B had actually remembered the phone call that they just wanted her husband's weight and didn't think very much about the treatment had been explained to her. But she said she'd have consented to the treatment if she had been asked. So this is a point the HDC is often very concerned about, consent. In a situation where there's significant time pressure, that time to thrombolysis is rapidly closing, the patient's not able to sign a consent form, is it okay to just take a verbal consent? Did the RMO have to ring the wife and get her to agree?
Unless you're doing, major surgery, I think verbal consent is actually fine when giving medication, so long as you document that well. And that's the important part, the documentation of what you've explained. And in the documentation, you should include all the specific risks discussed and any statistics that you've explained, as well as the potential benefits of that treatment. That being said, there are hospital protocols. So if there's a consent form that needs to be signed, often you really do need to sign it, just because it is part of protocol. And I think that the fact that no one had advised the house officer about this, I don't believe you can put any blame on the house officer. I feel sorry for this particular doctor. They were put in a position in a small rural hospital where there are no other people to really contact without, breaking that threshold of I've got to wake the SMO up, and they haven't got enough information to be able to do this easily. So I do feel sorry for them. But in this case, I think verbal consent that's just documented is fine.
And that's also assuming that the patient had capacity. Significant neurological deficits may affect a patient's ability to understand and weigh up the risks and benefits of the recommended treatment. If there's any doubt about capacity, clinicians may have needed to proceed in the patient's best interests, with clinical consensus another reason to have appropriate senior clinical involvement.
And the SMO remembers Dr. A saying that she had explained the risks of thrombolysis to Mr. B and to Mrs. B and obtained verbal consent. However, that phone call wasn't actually recorded.
Yeah, I completely agree that verbal consent is sufficient. It's not one of those types of cases where written consent is mandated. I'm a little bit more puzzled about why the form wasn't used, even if it's just annotated that, Mr. B not able to sign, have explained the above verbally, and then the house officer signs. Because if it's part of the protocol and the house officer is doing something for the first time based on the protocol, that's where they're getting their information from. It depends how the information was presented, but if it's all living together, I would have thought one of the first things you'd do is print it all out, sit down and just turn through the pages and make sure that you understand everything in the protocol that you're about to do, including if the consent form lives in there, you think, okay, there's a consent form there. And if you don't understand anything in that protocol, you ring the SMO back and say, I know you told me you were okay with me doing this, but I've now sat down and read the protocol and there are parts in here I don't feel comfortable with.
Yeah, and now we're getting to the crux of what actually happened in this case, because Dr. A prescribed tenecteplase instead of alteplase. Now, as you remember, tenecteplase is for myocardial infarctions, and this patient had a stroke and should have been given alteplase. He used an appropriate dose of tenecteplase, which would have been appropriate if he had had a heart attack, but it's the incorrect medication for a stroke. Dr. A stated, "I was informed by the ED nursing staff that alteplase was not available. Treatment efficacy for thrombolysis for stroke is time dependent. It must be commenced within a maximum of 4.5 and ideally within 3 hours. And Mr. A's care had already passed the 3-hour mark by that time. I was advised that tenecteplase was available, and although not yet licensed for treatment of stroke in New Zealand, there is evidence that tenecteplase can be used for stroke, and it's in the same class of drug as alteplase and works in the same way. Therefore, I decided to proceed with thrombolysis. My intention at all times was to achieve the best possible clinical outcome for Mr. A within critical time constraints for thrombolysis." So Dr. A didn't contact the SMO to discuss this decision of substituting tenecteplase for alteplase, but he did tell the patient that the drug of first choice wasn't available and that he was going to be using a similar unlicensed drug instead. So the ED nurses had said that they didn't have any alteplase. What should Dr. A have done at that point?
I think the junior doctor should have called the SMO at that point, because it is a significant clinical decision. And based on how the case has been described, the nature of what was agreed in the initial call was, "I'm comfortable with you doing thrombolysis in accordance with the protocol. I don't think I need to come in for that because there's a protocol to follow." And as soon as you're doing something that is not consistent with the protocol, you've departed at that point from the nature of, I want to say agreement or permission, I'm not sure what the right word is, but the plan that was formed between the consultant and the junior doctor in the phone call is no longer able to be executed. So far as the junior doctor is aware, that's the point to revert and say, "Look, I'm not able to follow the protocol because the right medications aren't here." And I think had that call been made, it probably would have been very rapidly ascertained by the consultant that the patient's still an ED, and that's why they can't find any tenecteplase, because the ED doesn't hold it. And the patient ought to have been in ICU.
Yeah, I think generally speaking, if you deviate from a protocol guideline pathway, anything like that, you can do it, but you need to have a good rationale as to why you're doing it, and you need to document that well. And as a house officer, that's probably not your role. Deviations from guidelines ought to be made by someone more senior, I think. And, I mean, look, in the cold light of day, it's easy for us to say that. The house officer was probably in a very difficult situation. It was in the middle of the night, and there was a lot going on for them. So, would someone else have made that same error? Quite likely. But, so I don't want to be too harsh on the house officer.
Absolutely.
But the reality is, if you deviate from a protocol, have a good rationale.
I think that window of thrombolysis time pressure thing is actually it's a big pressure to think, I've got to get this done.
That's
this
right.
patient's had a big stroke. We've got to get that clot out. I think that actually probably played a part here. And look, interestingly, an ED nurse then rang ICU and asked if tenecteplase and alteplase were the same. And the ICU nurse said, yes, they were. But the ED nurse didn't say, have you got some alteplase? She just said, are they the same? And the ICU said yes. The nurse said yes. Now, the ICU nurse remembers being asked if alteplase was the same as actylase, which is the brand name for alteplase. And so she said they were. So obviously that in the middle of the night, one person's saying tenecteplase, the other person is expecting to hear actylase, and actually mishears that. And that would have been another point where, there would have the opportunity to see what was going on. interestingly, that ICU nurse, having been asked about alteplase, thought, oh, there's a patient coming with a stroke, and got the alteplase infusion ready for the patient because she had alteplase, because she understood that this patient was in ED and assumed that they were coming. So here we have a pure miscommunication. The ICU nurse heard probably what she expected to hear, which was actylase, and said that that was the same as alteplase. For whatever reason, those words were muddled up. How would the HDC view that kind of mistake? Adam, what do you think?
I'm not overly familiar with this particular HDC opinion, so this is my gut response to it, which is that it's relatively inconsequential to the key things at issue and what went wrong for the care of this patient. And I doubt that the HDC would get overly involved in trying to run to ground whose memory of that phone call was correct. It's a side issue in terms of what went wrong. The nurse has done the right thing to make that call. That's a proactive step to take. In the end, it didn't add to the quality or improve the quality of care because there was a miscommunication. But I doubt that anyone would be criticised for attempting to add to the quality of care in that way.
I think it's a shame that the ED nurse didn't just make that join some more dots. Got a patient with a stroke. The ED nurse clearly knows that they get thrombolyzed in ICU because they call ICU nurse, but doesn't actually communicate that to the house officer. It's a missed opportunity, isn't it? And I think it's a big shame for all of them, including the patient.
Yeah, and Dr. A was not aware that alteplase was available in ICU, or that the infusion was actually being prepared in ICU. And when she did become aware 20 minutes later, he rang the SMO, who was not familiar with using tenecteplase for stroke, but thought that actually we've started that, that swapping at that point was probably the wrong thing to do. And she said she was not aware that Mr. A had been given tenecteplase according to guidelines for heart attack patients, or that the recommended dose of tenecteplase for strokes would have been different. So at this point, the SMO is aware that the patient has been given tenecteplase, doesn't know what dose it is, but says continue with it rather than swap to alteplase because she's thinking we can't really use two thrombolytics, and we've started this one. So has the RMO's done the right thing here and asked the SMO? The SMO's in uncharted waters. What's the issue here? Is it different from an RMO making this type of call when the SMO has decided to continue?
It's certainly easier for the RMO when it's the SMO that's made the decision.
Yeah.
But the reality is any clinician who makes a call around treatment of a patient takes responsibility for that. So the SMO needs to, I assume, will have had to respond to the HDC about that particular decision. I think it just underlines the seriousness of the decisions that we make as doctors. That any time you make a decision, you're held responsible for that. And we make decisions all day long, don't we? And you can never... There's a lot of uncertainty in medicine at times, and you have to be able to be okay with that and making calls that you don't necessarily know are 100% correct. But if there, you have safety as an RMO because you can pass the buck up, and if you can, then I would.
And look, the infusion was stopped soon after anyway because an ICU nurse recognised the dose of tenecteplase was wrong. And Mr. B actually initially improved with the infusion, but later deteriorated and very sadly died a few days later. So maybe now we need to have a look at what went wrong here, and I think we can all see some of the issues. Sam, do you want to take us through what the learnings are from this case?
Yeah. So the RMO obviously felt pressured for the patient to get thrombolyzed within the appropriate time window, and decided to provide treatment which he wasn't familiar with. The SMO didn't come in. There was nothing in the report to say the RMO was specifically had asked them to. ED nurses weren't familiar with stroke pathway, and neither they nor the RMO realised that it was supposed to happen in ICU. The fact that alteplase was not available in ED. There's a whole lot of things, a chain of events really, all those holes in the Swiss cheese that lined up. And the RMO chose to substitute an alternative drug without checking. So I think in learnings from this case, when you're not sure about a treatment or if something unexpected comes up, it's important to ask a senior doctor, even if it means waking them up at night. And I know there are pressures because often you want to be seen to be competent, you want to be seen to be known what to do, you don't want to be embarrassed because it's kind of like, is this a dumb question? All of those things. But at the end of the day, you've got to remember that there is a patient at the end of this and what the risks are to that patient. So ask if you need to. And if you feel a situation is beyond your level of confidence or competence, specifically ask someone to come and help you. There is nothing wrong with that. And you'll be faced with so many firsts in your first couple of years as a doctor that I think, it's important just to get used to the fact of, I need help. Would you mind coming and showing me? And you can do it politely, but I think to be assertive in that. And when you're feeling time pressured, that's the time to take extra care, because that's the time often we might cut corners or we might make decisions that aren't necessarily well thought out. And in terms of your verbal consent, particularly for where there's risk, good documentation is always important. So there's a few lessons there, but I remember when I read this case from the website that the RMO involved, it deeply impacted them, and you can imagine that, can't you, early in your career to have something like this happen. And for our listeners, I think there are lots of lessons there, but just I guess I'd like the listeners to go away with the thought that yes, sometimes serious things happen, despite the best of care, but that it's okay in the end. You will get through it, and that there's no reason why you can't go on to have a really great career. And I'm really hopeful that the RMO did so in this case. I'm sure it impacted them, but I'm hopefully in a good way ultimately.
Adam, what do you think? Have you got any kind of things that stand out in learnings for
It's
junior
easy,
doctors?
easy to be wise in hindsight, isn't it? When you look at all that laid out and think, call the boss would have been the right thing to do at various points in that journey. But Sam's right that it is the nature of medicine that it is often high stakes, and that doctors at all stages in their career are asked to or put in the position of making very consequential decisions. And with the best will in the world, nobody makes the right decision all of the time. All decisions will fall on a normal distribution. Sometimes the decisions you make will be suboptimal, and that doesn't mean you're a bad doctor. If you're lucky, those poorer decisions won't end up having a meaningful impact on patient care, but they might. And that's a reason why medicine, I'm sure, can be so rewarding, but also a reason why medicine can be hard and stressful, and a reason why if something's gone wrong, you should reach out for help. Not just medico-legal help, but support from colleagues or counsellors or people who can have those sort of conversations with you. Because nobody wins if people change a specialty because of one bad day, or even worse, walk away from medicine. Actually, doctors who have had something bad happen and managed to get the right perspective on it and learn from it and become even more thoughtful and careful clinicians, we all benefit from that, patients and society. So do reach out for help, and don't make quick decisions if you're in the depths of struggling through something like this. Make sure you take some time and do it with the support of friends and colleagues.
Look, I've had my own complaints in my career. Early on, and as a GP, I had what I felt to be a really significant complaint. And I think, Lucy, you have too.
Mm-hmm.
And
I think most of us have.
Yeah, most of us have. And so just know that you're not in it alone. We all make mistakes. Some of us probably many of us go through really difficult cases like this. And we do get through it. And just as Adam said, reach out for help. And if you're a member with us, we're here to walk with you every step through the process and to provide as much support as we possibly can to ensure that you not only get through it, but you come out the other end and you're just good to go with the rest of your career.
And you'll have learnt a lot. And your colleagues will have learnt a lot, I think, we all learn from each other all the time with these things. And I do think one of the things here is this doctor was at every step was trying to do the right thing for the patient. It wasn't done lightly, or, was always trying to do the right thing. And yeah, as Sam says, I hope that that has had a long-term, has had a good impact on their career. So thank you for listening to this podcast. I hope it's been helpful. Our podcasts provide information of a general nature, but if you want advice on a specific case and you're our member, please contact us on 0800 2255 677 option 3, or call 0800 call MPS option 3 during business hours. We do also have an after hours number for urgent cases. We look forward to catching up with you in our next podcast. If you like Medical Protection podcasts, please subscribe and leave a review. If you'd like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org.